Welcome to episode 19 of the Walk and Talk Improvement podcast series. I'm your host, Dr. John Fitzsimons. I'm a pediatrician at CHI in Temple Street, and I'm clinical director with the HSE National Quality and Patient Safety Directorate, and I work with the RCPI in Quality and Patient Safety Education. This episode focuses on diagnostic safety, the theme for this year's World Patient Safety Day, which is happening on the 17th of September. In part one of this special, I'll be speaking with Professor Eva Doherty, who is a clinical psychologist and Director of Human Factors at the Royal College of Surgeons Ireland, on the psychology of diagnosis, including the impact of cognitive biases and the human factors elements in the diagnostic process.
Diagnosis is an essential part of healthcare. It is very often the first step in healthcare. It can be defined as the process of identifying a disease, condition, or injury from its signs and symptoms. A health history, physical examination, and tests such as blood tests, imaging, and biopsies may be used to help make a diagnosis. Traditionally, diagnosis was the remit of doctors and may be even seen as a defining part of what it means to be a doctor. But nowadays, many other healthcare professionals make diagnoses, including clinical nurse specialists, advanced nurse practitioners, and many health and social care professional roles will involve diagnosis, including pharmacists, psychologists, occupational therapists, physiotherapists, dietitians, as examples. Patients are also playing an increasing role in diagnosis, with improved medical literacy and access to medical information once exclusively only available to healthcare professionals. Many patients are willing and able to play an active role as partners in diagnosis. In developed countries, diagnosis is responsible for about 10% of healthcare expenditure, a proportion that is increasing faster than other areas such as treatment or care due to new testing capacity and the ability to extend our diagnostic capability. Diagnosis can be simple, but it can also be very complex. And because it is so pivotal in terms of determining prognosis, prevention, treatment, it is also potentially dangerous. The reason why WHO has picked it as the topic for the World Patient Safety Day is recognizing this. We know that many people will experience a diagnostic error throughout their lifetime. Recent studies have shown that 5% of patients in outpatient care in the US, 4.5% of patients in primary care in the UK experience a diagnostic error each year. Post-mortem examinations spanning decades have shown that diagnostic errors contribute approximately 10% of patient deaths. Medical record reviews suggest that diagnostic errors account for 6 to 17% of hospital adverse events. And in the US, diagnostic errors are the leading type of paid medical practice claim, and they're almost twice as likely to have resulted in a patient's death compared to other claims and represent the highest proportion of total payments. As I said earlier, diagnosis is a process. And in a landmark report from the National Academy of Medicine in the US in 2016, this was acknowledged and described in detail as a model. And I'd like to describe that model to you for a few moments. The purpose of the model is, first of all, to achieve a timely and accurate diagnosis, but also to communicate that diagnosis in a person-centered way. The beginning of the model is the patient experiences a health problem, and they take the next step, which is to go and engage with the healthcare system. This starts what is called the diagnostic process, which is an iterative process of gathering information, perhaps then having a physical examination, and then looking for tests or for consultations for extended opinions. And it's iterative because what we find on the first iteration will inform perhaps the second iteration or third or multiple iterations if we need to look for further information. And this leads to a working diagnosis and ultimately to a final diagnosis. And that diagnosis then needs to be communicated to the patient and to their family, and then results ideally in treatment if required. And that diagnostic process happens within a work system that contains many, many other people and multiple other processes, such as laboratories, radiology departments, many colleagues and other healthcare professionals, and is also underpinned by things like information technology to help to gather those results and information, and also to communicate them. So as you can see, it's a complex thing. And because it's complex, we know that things can go wrong. And one of the first places that I'd like to think about today for the podcast and where they go wrong is in that diagnostic process, the gathering of information, the using of questions to take the patient history, examining the patient, and then looking for investigations. And that there's a lot of psychology happens there and how we bring that information together and how we think about it. And I think this is one of the places that we know is accountable for many problems with diagnosis and diagnostic errors. And I'm fortunate to be joined today by Professor Eva Doherty from the RCSI, and Eva's a great interest in human factors and heads up the human factors program there. And I'd like to talk to Eva a little bit about how we think about diagnosis and the role of psychology within diagnosis. Professor Eva Doherty, you're very welcome to Walk and Talk Improvement.
Thank you for having me.
Eva, you're a psychologist. There's a lot of psychology in diagnosis, and diagnosis is made by people. And we know that there are particular problems with how we think in relation to diagnosis. Could you describe maybe some of the recognized problems that there are with the making of a diagnosis?
Okay, thank you for that question. I think what a lot of people maybe don't appreciate is that our brains are really very unreliable. They're not necessarily, as I say, to be relied upon. If anybody's interested in, reading more about this, I can recommend Daniel Kahneman, who's the, first and only psychologist to have been given, a major award for his book, Thinking Fast and Slow. And because what he identified, and I certainly, when we're teaching our doctors, they really latch on to this, is that, the system of thinking in our brains is that we have two systems. We have a very fast system, which serves us really well most of the time, system one. And then we have a slower system, which is called system two, which is logical. It doesn't make mistakes, but it's slower. Now, we actually spend most of our time using system one, which for the most part does us okay, but we can trip up at times. And I think this is where the whole research on bias and heuristics comes in. So, biases are prejudiced ways of thinking that we don't question. They can be quite, they're not even conscious. We're not even aware that we're doing this. Again, if people want to explore this, they can go on the implicit association test website, which is run by researchers in Harvard. And if you agree to be a subject, it's easy peasy. You just give your consent. You can test yourselves for nothing. And you can find out if you harbor biases, about, black people or white people or thin people or not thin people or disabled people or healthy people or all these things. It's very enlightening.
And we all have these biases.
We do.
There's no shame in this. It's just the way we are.
This is the normal way, the way the brain works. And as I say, it serves us very well for the most part. But there are times, as in making diagnoses, where we can trip up. So, for example, and the other point to make is that there are literally hundreds of different kinds of biases that have been identified. Some of the most common that people might be able to relate to is what was called the confirmation bias. So, somebody comes in maybe with, a sore throat and a sore ear, and you kind of think, oh yeah, I know what this is, upper respiratory tract infection, that's grand. And then you don't continue to look for more information, and you can make an incorrect diagnosis perhaps. Another bias is anchoring bias. That is, where we get stuck on something and we refuse to take into account information that's coming along that's not agreeing with that. Another one, a common one, is what's known as the availability heuristic. And I often use the analogy, when 9/11 happened, nobody got on a plane for a long time, even though that was probably the safest time to get on a plane. And then there's other ones. There's overconfident bias, the belief that, your intuition is very reliable. There's what they call the commission bias, which again is a common one we see in medicine. Somebody comes along to you, in truth, maybe nothing should be done, but you feel like you have to do something. And so you write a prescription for whatever, even so. And then there's premature closure, which is, again, similar. And there's a lot of overlap in these. They're not necessarily distinctly different. And that's, kind of deciding, I know what this is, prematurely.
And you mentioned the term heuristics there. What are heuristics?
So they're like shortcuts. So I suppose the best example of that is, when you look at your nearest and dearest, it might surprise people to hear that you're not actually analyzing their face right now in the here and now. You've actually gone into your memory store and you see the person that you know really well from your memory store. So our brains are basically lazy. If there's a shortcut, they'll take the shortcut. And that's why sometimes you might see a friend come your way that you haven't seen for years, and you might not recognize them until they come up close. And people can actually start to become younger, right in front of your eyes, because you're reverting to your memory store. So that's, so again, they're shortcuts that our brain takes.
And why don't we just use this slower system all the time? Why don't we, if that's the source of the problem, why don't we just spend our time in this slow system?
Because it's very cumbersome. We can't, we have a limited sort of working memory. Again, people might be surprised to know that we can really only hold, 5 plus or minus 2 chunks of information in our heads at any one time. That's why if you're feeling a bit overwhelmed, you probably need to start writing things down. But yeah, so system 2 is very clunky. It's very cumbersome. It's not quick. So that's essentially why.
Yeah. So in order to get through the day, to get our work done, we have to be relying on system 1 a lot. And obviously being aware of these heuristics and biases is useful, but is there anything else we can do to compensate for this?
So and that's the great question, because the evidence is that we cannot untrain our brain, or train our brain, if you like, not to fall victim of these biases and heuristics. It's just the way our brain works. So what you have to do is you have to, exactly as you say, you have to compensate. So you have to figure out safety netting, safety nets that will catch the potential mistake and, trigger us to have another think about it again. And that's why, things like we teach psychological safety in our teaching. It's a massively important part of human factors, because people need to be able to feel safe in questioning. So, if I'm working with you, John, and you decide something is a whatever, I need to be able to say to you, well, sorry, John, because hopefully the hierarchy is flat and I'm not calling you Dr. Fitzsimons. And I might say to you, sorry, John, are you sure about that? Because I'm not so sure, because I've been looking at, these test results and whatever. Yeah. And that you don't, kind of get it cross with me. And you have another think and you go, maybe you've got something there. So, that's one really important thing. But I think technology has a lot to offer us. When you look at the evidence in the literature, it's all about computer assisted prompts to make us rethink. It's all about audits. It's all about checks. I mean, if you think of it, the WHO safety checklist is all about that. The early warning score is all about that. The ABC in, trauma management is all about that. So the more these checks, the better.
Yeah. So from a human factors point of view, it's recognizing that we're flawed as diagnosticians, as humans, but there are things that we can do with other people and with technology possibly to help us to avoid these pitfalls and to compensate for some of the problems that we have.
You see, I think that's the great myth in healthcare, that people have to be 100% accurate in everything they do. I was listening to Roger Federer talking lately on a YouTube video, and he was talking to a whole load of graduates in Stanford. He'd just been given an award, and he said, out of the 1,596 matches, he only won 80% of them. And out of that, he only won 54% of the shots. That means 46% of the time he made a mistake. This is Roger Federer we're talking about. We have to actually do exactly that and realize we are fallible, and that's an essential principle underpinning human factors. That's how it all started.
In the National Academies of Medicine document I described, and model I described earlier, they give a lot of importance to the communication of a diagnosis. What's important when you're communicating a diagnosis?
So now, do you mean making the diagnosis and giving it to the patient, or do you mean actually reaching the diagnosis in the first place?
I think when the diagnosis is made, but also maybe perhaps the communicating the process, and we recognize that there's a lot of uncertainty in the process of diagnosis. How do we communicate that with patients and families that means that they're aware of it, but not perhaps overly concerned by that burden, but can understand it?
So there's a number of things that really help that process. I always remember Johnson Silverman, who's very famous and well known in this whole area, says that a lot of doctors confuse the content of what they're searching for as being the exact same as how they go about it. So it's a little bit like you might want a lovely garden, but it's not about putting a whole load of plants into the flower beds and thinking that's going to be a lovely garden, because there's a whole process that you have to go through. And it's the same with this gathering of information. And part of that is, and I think, there's a lot of improvement that could take place here. If doctors are sharing their decision-making process with their patients and families as they go along, and if they are doing what we call signposting, so now I'm going to ask you about this, and so now I'm wondering about that test result, and so now I'm going to examine you, and now I'm doing this, and now I'm doing that. You're bringing people along with you, and then so when it's time to actually explain what you think it is, they're likely to be almost there with you at the same time. And very often, if it's a really tough diagnosis, they'll often be there as well, and they'll often even do the hard job for you, and they'll say, this isn't looking good, doctor, is it? And you'll go, and then now all you have to do is confirm and say, well, yeah. Whereas you don't have to make this big, huge announcement, at the very end. So I think involving patients and sharing what is going on in your mind the whole time is crucial. Asking open questions all the way through is also crucial. There's really good evidence that doctors, do not use open questioning as well as they could. And this means they often they miss out on a lot of information. They're often inclined to interrupt patients. We know that's actually getting worse in healthcare. It's, the average has gone down now to about 11 seconds before a doctor will typically interrupt a patient. Whereas patients will stop talking after about a minute or a minute and a half. And I challenge anybody out there listening to try that out and see, does it work? Because it does work. And again, it comes in really important then, in the whole area then of making decisions with the patient about what's going to be done, what's going to be the recommendation, what about the treatment. And that's where the shared decision-making comes into things. And I think a lot of people think that shared decision-making is handing the decision-making over to the patient. It's not. It's about sharing your own view, what you think should happen, and yet matching that to the values and the preferences of the patient and their family, and coming together I had somebody, tell me lately they were there for a consultation about a hip replacement, and they came to me and said, well, I don't know what to do. The doctors have to tell me to make up my own mind. Oh, I don't know. I'm not a doctor. So that's not shared decision making.
Yeah. So listening, signposting, sharing those decisions throughout and communicating that throughout the process of diagnosis, not just at the end of the diagnosis is made.
Absolutely. And doing another thing that we call, which is called periodic summarizing, which is a really clever way of gathering your own thoughts together, hearing yourself saying, what you think is going on. That also tells the patient and the family, you're really listening, you're really thinking this through. If you've got any biases, that you're going to hear yourself express them, and you're going to go, oh, wait a minute, sorry, now I'm jumping the gun here a bit. So it's a great check. So it accomplishes a whole lot of things. And doctors tend not to do it as much as they could. And then on top of that, the big thing, and anybody who comes to our training knows how big I am with this, is demonstrating empathy. It's not enough to just feel that empathy in yourself. You actually have to say it out loud. So you actually have to say to the patient and their families, this is so difficult. This is so hard. And I think that's where a lot of people fall down. They feel it inside them. I've never met someone who's not empathic, but they don't say it out loud. And that encourages your patient and the families to say more, to give you more information. The more you can get, the better.
And using communication to build that sense of empathy and the relationship during diagnosis that could be really helpful later on in treatment or in other aspects of care.
Big time. And again, there's a fabulous book that came out a couple of years ago called Compassionomics. I recommend it. It's each chapter is all about the benefit of empathy. It saves a fortune in healthcare. It reduces physician burnout. It leads to better diagnoses. It leads to better improvements in patients' adherence. It just achieves so much. It's, if we could bottle it, we could make a fortune. It's simple to do once you get into the hang of it. But you have to make that shift in your head that you have to say it out loud. Another really super resource I can recommend, it's Canadian, I think, is Choosing Wisely. And that has so much information on it, but it's lovely. It's got this very handy section, 5 things a patient should make sure to ask their doctor, 5 things the doctor should make sure to ask their patient. So I recommend that, and it's all about, as it says, choosing wisely. Another really great resource, which has been recently developed by the HSE and which I highly recommend, is My Health, My Voice. Anybody going to see a doctor should definitely have a look at this. It's got lots of resources in it, but it's got 3 great questions that patients need to ask their doctors. What do I need to know now? What do I need to do next, and why? And what can I expect? And I think what's important about this is doctors listening here and nurses. These are questions that, you're going to be asked. And so think about that and think about what are you going to say when you get those questions, because they're not usual. They're really, really important questions, but they're not the norm. And they're the kind of things that, as a patient, we might forget with, everything that's going on easily. If people are interested in enhancing their communication skills, they can find out about the National Healthcare Communication Programme. Very unique program in this country and even in the world, would you believe? And they have an app as well. If you go into where you get your apps and look for the NHCP, and there's lots and lots of information in there, really helpful resources. But you can also attend one of their courses on various topics.
One of the other approaches to improving our ability to make better diagnosis is called diagnostic calibration. And that's where we were able to reflect and learn about our own individual diagnostic process and the importance of feedback in order to make sure that we're accurate, but not overly confident. What are your thoughts on that?
And that's coming down to awareness, isn't it? You know, awareness that that's a trap that we can fall into, and awareness to, you know, always stay humble and, you know, never getting to a point where we think we're a rock star and that, you know, we can't make mistakes and we're always getting it right. You know, because that's obviously not safe.
And again, the critical importance, I suppose, of psychological safety there in terms of being open to someone pointing out that perhaps you've made an error or missed something.
Absolutely. And you know, Amy Edmondson has done a huge amount of work on this. She's got some fantastic TED Talks. And something that's always come across to me is, you know, how she advocates for what they call the mastery model. So leaders never put themselves out there as being, you know, all knowing, all capable. That, you know, the most effective master, we know this from psychology, is that the most effective role model is somebody who demonstrates a mastery approach. So we, you know, as leaders, we struggle with situations, but we know what to do and we know where to go and we know how to solve it. That's a much more effective role model than, you know, the all capable, all knowing, you know, rock star in inverted commas.
Yeah, I often give my team permission at the beginning of the day. I tell them I'm probably going to make a mistake somewhere along the way. Please point it out to me as soon as I do, and don't leave me with it not knowing that it happened.
Absolutely. And with us in the College of Surgeons, you know, the best surgeons are the ones who say that at the start of every procedure. You know, keep an eye and, you know, give me feedback afterwards and, you know, we can all get better.
Professor Eva Doherty, thank you so much. Up next, in part 2 of our World Patient Safety Day special, Professor Doherty and I speak with Dr. Hardeep Singh on diagnostic excellence.